Hey everyone, I am Kelly Crosbie. Thank you for that introduction. And I was here, oh my goodness, I think in the fall I met with y'all just to give an update on advanced medical homes. It was the original rollout. A lot has changed since then. We've done a lot of training and outreach, lots. How many folks have attended some of the webinars? Fantastic. You should recognize this webinar. It was one that we did. Trust me, I'm not going to go through it all again. But it is kind of my starting off point to talk about certain things. So just a couple things about Advanced Medical Home you won't see in the deck. We launched the program in October. We had guidance documents out in the field last summer. We launched the program in October, so that meant we launched trainings, a series of regional forums across the state, and we opened our attestation portal so providers could go in and attest to being an Advanced Medical Home Tier 3. As of today, we're about a third of the way to the goal. So we have a lot of information on who is attesting, where, and which region, what CIN or what system they belong to. And so we are continuing our outreach, though, and our education on what AMH Tier 3 means. When I talked with Melanie and Kristen and Danielle about coming back, we really wanted to hit where we are today in the model. What do you need to know now about the model prior to launching managed care, excuse me. So I'm going to talk pretty heavily around technology today, by and large. It's toward the end of the slide. But I'm using this slide today as a jumping off point, which is part of our communication to individual providers has been the care management requirements are pretty heavy. And so you might want to work with a clinically integrated network. Here's what they can do for you. So in Medicaid, we have a balancing act. We know a certain percentage of our practices are affiliated with systems or affiliated with a physician group already, but a large majority are not. And they have a lot of questions about how they can be a medical home, do all these care management functions, and what's the benefit of joining with a clinically integrated network. So that's kind of where we are today. Training folks about do this with a clinically integrated network, and let's talk about data. Let's talk about the data that you need to do this. At the end of the slide deck, I'm going to show you our sites again, so you can see our sites, you can see our training, and you can see where we posted additional information on the model. So also forgot to say, hey, it was nice to see a lot of familiar faces. Hey, Angela.
How are you, Kelly?
Worked with Angela for some time. In Medicaid last year. So, but nice to see a lot of familiar faces. I want to leave lots of time for question and answer. I prefer that. I prefer you guys to ask questions and I can answer them. My disclaimer is we are in the silent period. Everyone knows that. So we are reviewing bids right now for our managed care plans across the state. So that's not really a disclaimer. I have nothing to disclose. I have nothing to disclose. I was supposed to say that as well. I have nothing to disclose. But also we are in the silent period. So everything I'm telling you today is public information. There's no insider information here. All of this has been published, trained on, produced. It's in the RFP. It's out there for the general public. All right. So the things that this slide covers is just a general overview of the Advanced Medical Home Program again. The roles and responsibilities of the health plans, medical homes, and clinically integrated networks or partners of Advanced Medical Homes. I just wanted to give you guys a taste because I feel like I'm talking to, by and large, folks who belong to CINs already. So you probably are CINs, ACOs, technology partners of CINs or ACOs. So I'm telling you guys what we've told the field of independent practitioners about what they can expect from you. So we talked with them about three main ways that CINs, and I'll talk about that term a little bit more in a bit, can help practices through helping them with care management, helping them with data, which is going to be huge, and potentially helping them with contracting with health plans. We also have some use cases. I probably won't go through those, but I think they're helpful use cases when we at the state have visualized how advanced medical homes work. All right. So the state has invested a great deal historically in local care management. I think you all know that. Our care management model, our medical home model in North Carolina is well known. We don't want that to be lost in the transition to managed care. There's a lot in that RFP around how we want care management to be local. We have required subcontracting provisions in the RFP around contracting care management to medical homes who feel ready to do it, and contracting locally with our 83 health departments for the provision of high-risk pregnancy care management and care management for at-risk kids birth to 5. So in addition to all that required subcontracting, we really want health plans to have a plan for local care management. How's it delivered in the community? How are we reaching beneficiaries right there where we are? We are investing a lot of dollars in care management as well. When we've gone around the state, we've talked a lot about that rate book that's out there with the RFP. The care management money is right there for all to see. For those that know what we currently pay, it's a heavy investment in care management. We expect lots of local care management. Okay, so local care management, I just stole the thunder on this slide. Health plans have to have local care management plans, and they have to subcontract with advanced medical homes and local health departments. I'm assuming most of this is, you know this already, so I'm kind of breezing through it. Okay. So we have also laid out in the RFP our care management requirements. We've learned a lot from other states who have been relatively laid back about how care management happens. We've taken a rather different route. We've laid out our expectations for how care management happens, how the process happens, as well as for the populations that have to be targeted with care management. Again, this is old information, you've seen that. We expect all beneficiaries to have a health risk screening, we call it a care needs screening. We expect our health plans to do really good data analytics and identify people who could benefit from care management. We have expectations around penetration rates of care management, actually, that we'll be talking with the health plans about. And then we expect everyone who gets flagged to have a really good assessment and then get really good care management. We've also specified specific groups who need to be targeted for care management. It's not just high cost, high risk folks. The industry has moved very far away from that anyway. But we're asking folks to target rising risk. There are new federal provisions that everyone with LTSS needs is entitled to care management. That's a really important group for us right now. There's a lot of folks with LTSS needs who are not in skilled nursing facilities, who are not on a CAP C or CAP D waiver, who are here, or will be in the health plans. Individuals with special health care needs, that's been defined in North Carolina for a long time as people with co-occurring physical and behavioral health issues. And then folks with rising risk. Is that 4? Because there's a 5th. Did I get my 4 or 5 wrong? Folks with high unmet resource needs. So that's an important one to us. Today is not about the care needs screening, but in the care needs screening, we will have mandatory questions around addressing our 4 domains, or resource domains: food, transportation, housing, and interpersonal violence or safety. I try to say it in a positive way. I don't like that answer, but yes. So we have standardized questions. We expect health plans to have other unique ways for how they identify individuals with high unmet resource needs. We expect them to have care management delivered, whether or not they have serious chronic health issues, okay? So we have high expectations around health plans having methodologies for identifying these individuals, which we will okay, and provision of care management to these individuals. How does this translate into advanced medical homes? Pretty much everything in blue or striped. We also expect of the advanced medical home tier 3s. You've seen this presentation before, so I'm gonna stop saying that, but what we're trying to create with advanced medical homes, and we're trying to do a better job of articulating that, is we really are doubling down on primary care. We just are. We want primary care to evolve. We want primary care physicians to work together in clinically integrated networks. We want them to own the health of the population of the people that they serve, regardless of payer. We want to align with other payers and how they're paying for healthcare. We want to pay for value, not just pay for widgets. So part of moving the advanced medical home model is saying, okay, how can we build on what we have? How can we take folks to the next step and say, well, a lot of other payers are paying for care management. We're going to pay for it on a population health way, but you have to be able to do it, and doing it means a lot of things. But with that comes other things too. You're not just doing care management, you're having flexibility of payment, you're getting incentive payments, and we're helping you towards becoming your own little population health units. That's really what we're striving for, okay? All right, so why CINs? That's kind of where we're ending up, right? Health plans are working with advanced medical homes. We expect many advanced medical homes to work collaboratively as groups of physicians partnering together to really have the resources they need to manage their population. So we are using the term CIN. We're stealing the term. We know it's a term. It's a federal term. It's out there in the literature. If we could go back 6 months, we'd probably pick another term. We've gotten a lot of flack for using CINs. I would also say, like, if you could put CIN in little letters, like we mean it in little letters. We mean it to describe a group of physicians. We don't care if they're independent. We don't care if the makeup includes primary care and specialty physicians. We don't care if it's a hospital-owned or a hospital-affiliated system. Go and God bless. We say CINs and other partners because we know a lot of times you might have a physician group, right? Be a group of 50 physicians. 40 are primary care, 10 are specialty care, but you also contract with a care management vendor for technology and care management needs. So we are saying we know that a physician who's going to get a capitation rate to do care management will likely have to collaborate with another group of physicians and potentially collaborate with other partners who have maybe the technology resources they need to be successful. We are totally agnostic. Do it. However it works, you do it. We are enabling primary care practices with their dollar to go and purchase what they need, band together how they need to, and we don't care how that looks. We support what works. Okay. So what we talked about with providers in this slide is, well, let's give you some ideas of how we thought CINs could help providers. They're very obvious, okay? They're incredibly obvious. Actually help with care management, right? Actually the function of care management or some of the clinical oversight and resources. The really big way that I want to focus on today really is the data integration. I'm going to spend some time on the data slide because data's kind of heavy around care management. A lot of folks think about care management maybe for their own panel. And they think, I know the people that I need to serve for care management. It's very expensive for me to buy a care manager or to pay for a care manager, but I think I got it for my panel. We're asking for something a little more advanced than that. So data, it plays an important role in that. And the third thing is we think there's a lot of providers who could benefit from, as a collective, contracting with or negotiating with health plans. Okay. And there's like, I see Sean, I'm like looking at Sean, and I have attorney in my head. So I'm not trying to be an attorney when I talk about contracting, so know that. So. Sean was my general counsel. Right, Sean? Yeah, okay. First he grilled me in the General Assembly for many years, and then he was my GC. So, okay. It's good to see you, Sean. All right. So just to remind folks of the accountability model, I think I've said this again and again. Like, we at the state will contract with the health plans. Health plans will contract with advanced medical homes. Those are the folks that have to attest and say, I can do this. I will have to partner with someone likely, but I can do this. It's my dollar. I will spend it as I see fit. Okay? It's about empowering the medical home. So the AMHs will have the buying power to work, to band together with other professionals to use it, to purchase technology services if need be, clinical services if need be, but that's what they're purchasing with the dollars. Okay. At the state, when I said we're agnostic about CINs, I really mean that. We will certify practices. Practices can attest to being an advanced medical home. We are not enrolling CINs, we're not certifying CINs. For all of you that are official CINs, that's a huge process. We're not really interested in that right now. Okay. So how can CINs support this care management process? Really gonna gloss over these. So if you look at the attestation process, we have a AMH provider manual out there. We have lots of trainings. We had a series of 3 trainings on the clinical components of care management because it's a lot of stuff. It's very, what I will say is that, and I'll say this as a bureaucrat, and you validate what I'm saying, okay, don't just trust me. Our care management requirements are standard care management requirements. We at the state of North Carolina didn't make up care management. So God forbid, you do not want bureaucrats telling you how to do care management. But what we have is care management as it happens in the field. Our care management requirements will look a heck of a lot like you'll see from like NCQA. We did not take them from NCQA, but I'm saying they are industry standard. This is how you do care management, okay? We did set some parameters around, if you're doing care management for North Carolina, you better have this kind of training, And you better do a couple things that we think are really important, like medication adherence, medication reconciliation. And we really do need a physician to be able to consult. We need an RN or an LCSW over a big caseload. But otherwise, please be creative. Use community health workers. Use all kinds of multidisciplinary folks to do care management. But some of those things that I just mentioned to you right now, a physician, an RN, a consultant psychiatrist, that's not something maybe a practice can do, right? So perhaps that's something that your CIN can do for you. If you look at, for example, the CCNC model that we have built today, each of the local networks, part of what they bring is physician consultation, right? There's a psychiatrist there, there's RN support, there's pharmacy support. In a way, they served as a local clinically integrated network for the physicians in their system. So you can purchase that from a CIN if you so choose. So a lot of clinician support. You can actually just purchase staffing. You can purchase care managers from a CIN. There's a whole lot they can help you with from a clinical perspective. That's what we've been sharing with the field. Again, I'm preaching to the folks that are probably doing that for practices right now. Okay. A whole lot more clinical stuff, helping with comprehensive assessments. Managing transitions is a big thing, but I want to save that mostly for the data conversation. Part of what's really important about our current model and what we've put in the RFP is we expect great care transitions to happen of all kind, not just from inpatient to home. It's really important that you're helping folks transition across levels of care. That might be to another health plan. That might be to home. That might be back to fee-for-service. I don't care what it is. We expect really good care transitions. It's the right thing to do for our beneficiaries. A lot of that's very real time. So some of that, a CIN can potentially help you staff. Okay, data. Looking at my time, so I want to leave time for questions. Data is probably the biggest thing that when we talk with folks one-on-one, we've had some consultants go to the field and talk to CINs about their concern. Data has come up repeatedly as a concern. We know that data-enabled care management is just better. It just is. From our perspective, we're a population program. We're a population health program. We serve 2.1 million beneficiaries. We need to have a population-based approach. We need to use data to help identify the people that could benefit from care management. We can do it no other way. Pretty much the PHPs will have to do it that way. AMHs and CINs will have to do it that way. So in order to do good care management, you need to be data informed. Just do. A lot of the data in the system will now be housed at the PHP. Trust me, we will not make the mistakes of other states. We will have that data as well. But I'm just saying a lot of it will originate now at the PHP. So how do AMHs get that data? First, one of the things that we're suggesting is when I talk about the data that folks have to get, it's probably really going to be helpful for practices to work with a CIN or with a technology vendor to really help with some of this data. So here are some basics, easy stuff, right? Patient lists. All medical homes need to know who their patients are. You'd think that's easy, but you know that a lot of your patients don't come to see you, but you are responsible for them. And sometimes those are the folks that do need to come and see you because they are rising risk, okay? So health plans have to share with AMHs at all levels their patient lists. Health plans will be doing risk scoring, risk stratification. They'll be identifying high risk patients. I'll use a big category. They have to alert practices to who those folks are. So they know, hey, we've identified these two folks in your practice as probably high risk. Even though you're not a tier 3, you're not doing care management, just know that we've identified them, we're working with them on care management. When the health plan is successful at doing a health risk screening on an individual, they need to share that information with the practice as well. That's information that the practice may not have. And they also need to share quality measure performance. This is not information that the practice needs to calculate. This is information that the health plan needs to track, how you guys are doing on, or AMHs are doing on quality measures, and they need to share that with the health plans. All of that right now, we've said, we're not wedded to any specific format for how that is delivered to practices. That will go to AMHs of all kinds. Could be a flat file, could be a PDF, could be an Excel. It's okay because that isn't necessarily actionable data. It is, right? It is. You might do something with it, But for large part, especially for tier 1 and 2 providers, it's informational data, okay? Now what I'm gonna talk about is more raw data, raw uncalculated data that we need the tier 3s to do something with. The very first thing, of course, is encounter data. So in order to do really good data-informed care management, you need to understand your beneficiaries, their claims, who they're seeing, what medications they're getting, what tests they're getting. Y'all know this, right? Health plans will have to send advanced medical homes encounter data. That's probably the single biggest reason that most advanced medical homes will probably, tier 3s will probably have to work with a CIN or a technology partner, just for the capturing of that encounter information, but then creating that encounter information into actionable data, or using it to create actionable data, right? That's the data that you use, in part, there are other sources of data, to do good analytics, to identify individuals who have care gaps, or individuals who are rising risk, or individuals who have LTSS needs. All of those, not all, but a lot of those priority populations that we've talked about, you really need that encounter data to do risk stratification and scoring, which tier 3s need to be able to do. Other data, we are requiring that advanced medical homes get ADT data, admission, discharge, transfer data. There are multiple sources of that data in the state. HIE is working on their own data feed. Some of you are partners with the HIE. It used to be, I'm out of touch, the Hospital Association had an ADT feed, but there are a lot of vendors right now selling ADT feeds in a variety of delivery methods to folks. Part of the reason I mentioned the HIE, I'm not trying to endorse any one specific place, but it is a free commodity that providers are required to sign up for. So we are not mandating how you get ADT data, but you need to get it. So again, that's a technology component, and that's the data that you're going to use to find your transitional patients, right? Again, care transitions are incredibly important. So otherwise, these other two data sources are a lot, or the last one's a data source, the other one's a warning. It's just clinical data. I think we're all trying to crack the nut on how to get good clinical data. We work a lot collaboratively with the HIE. Is anyone here from the HIE? Say hey, my friend. Collaboratively with them, because we're invested in getting that clinical data as well as you are too. I know a lot of you are working with the HIE. But being able to share clinical data is really, really important. We need to go beyond encounter data at some point. But this is really sensitive. This is PHI. So anyone who's getting this kind of data also needs to have the right privacy and security standards in place to be able to maintain and collect this data. So data is a big lift. Does any of this data stuff surprise anyone? I know that I asked that wrong. I have to say that like a different way so you would like be willing to raise your hand. It's a lot. We understand that it's a lot, and we understand this is the single biggest thing we're probably going to have to work on end-to-end testing with, not just from us to the PHP and back, but from us to the PHP to the AMHs or their CINs. It's a lot, right? It's a lot of data that's going back and forth. But we are committed to enabling AMHs really start to own the data for their populations, to understand it, to make it actionable, and to really manage the health of their populations. The health, the quality, the total cost of care. So in January-ish, I don't want to promise too much, January 10th, I'll promise that date, we are doing a whole presentation, another webinar on this data and data exchanges. And we will be producing another issue brief explaining, again, more of this data stuff. Our goal is to not have the field surprised. The goal is to be out there as soon as possible to say, hey, if you are working with a technology vendor, they really need to be able to accept encounter data. And the format for encounter data are 837s, 837 IMPs for you technology folks, right? We send beneficiary files through 834 transactions. So these are things we want the field to be very aware of right now, so you can be smart when you're thinking of who your technology vendors are. Okay. All right. So, do I need to go on? Besides collecting your data, you want to use the CIN, or US CINs need to really use it and make it good. You have to be able to do good analytics on it. to get those real-time ADT feeds, or at least daily or twice a day ADT feeds, and identify patients who are transitioning and at risk of falling through the cracks. There's just a lot that CINs have to be able to do with the data. Remember, health plans are also sending a lot of data to AMHs, right? We fully expect that part of the reason CINs will get paid is to almost serve as a kind of buffer layer, if you will. So if there's 4 PHPs working with an AMH, their patient lists are going to their CIN. Their risk scores are going to their CIN. Their care needs screening results are going to their CIN. Because what we don't want is practices overwhelmed with getting data from so many sources. We're giving them dollars to help pick a CIN is going to help them consolidate the data they're getting from different health plans, get raw data from health plans, and make that actionable for them to use as a practice. Okay. Explaining risk scoring and stratification, ADT. This is a good presentation. You should hear the whole thing. Okay. The last thing that we touch on with providers is contracting. I just want to save, we're like low on time, and I want to save a few minutes for questions, but this is a recorded webinar. We also talk a lot about, without trying to step in any kind of legal issues, how we've had a lot of providers say, I just want to, I don't get, this negotiating is awful for me, and I don't know how much money to ask for in care management, and I'm afraid I'm going to get the short end of the stick if I try to negotiate with health plans. Okay, we want you to feel empowered too. So we are saying, as much as is feasible within the boundaries of law and whatever contract you sign with the CIN, we fully support, even though we're saying health plans, you enroll advanced medical homes, they are the place of accountability. If they say, hey, you negotiate with my CIN, here's my legal agreement, go ahead. If they say, you arrange data sharing agreements with my CIN, you send payments directly to my CIN, we have no problem with any of that at the state. We have no desire to get into the middle of any legal issues between medical homes, CINs, and PHPs. Know that to us, the area of accountability is the advanced medical home. It's not the CIN who's doing work on their behalf, but we want CINs to be able to offer support to our medical homes so they can do what they do, which is provide good medical care, right? So we really want them to be empowered, and if CINs want to negotiate, receive data, receive payments directly from the PHPs, we support any and all of that. Okay. Use cases here, if you want to see them. We've tried to give some relevant use cases to the field. Again, this is a recorded webinar. I'm going to do Q&A in a second, but I just want to tell you that here are some recent and upcoming sessions that we've had. In November, we did, I think it was the third in our series of, no, it was the second. We did the second and the third series on the clinical components of care management. We're doing transitional next week, so that's our emphasis on transitional. And then, as I said, on January 10th, we're going to do the data webinar. That is our website down there. We have a whole medical home website. It has the manual, it has all the recorded presentations, as well as downloadable copies of the presentations. And here is the list of, and I know that Melanie and Kristen said they were going to post this to your site or share it with you. If you don't know, these are all the many papers that we have published on the advanced medical home model, on the technology needed for it. We have running FAQs both for the model and for the technology required. So we're trying to get a lot of information out to the field.